Medurstand, Understanding Medicine.
Professor Azizur Rahman here. I am presenting another video and this time on a relatively uncommon condition. But uncommon conditions are also important because they often come in the differential diagnosis of common conditions. And of course rare conditions or relatively uncommon conditions also need to be diagnosed and managed properly. This is our curriculum, and today the number 24, pericarditis, and a condition which is very different but it causes similar ECG changes called benign early repolarization syndrome. That is also covered. So primarily I'm going to focus on pericarditis, and this is again a relatively short video. Pericarditis and benign early repolarization. The basic change in pericarditis is ST segment elevation, and the same primary change also occur in STEMI. So that is why it would require some detailed discussion how to differentiate pericarditis from myocardial infarction or STEMI. Uh, Although there are some other features and because pericarditis can also present with chest pain, so I think that makes this differential diagnosis even more important. I'm going to explain before I show you some ECGs. I'm going to explain how ECG changes develop and evolve in pericarditis. First step is ST segment elevation with concavity upward. Now, this ST segment elevation is usually global and usually subtle as compared to ST segment elevation of myocardial infarction, which may be very, very gross, maybe 10 millimeter elevation. ST elevation in pericarditis is usually 1 to 3 millimeter max. And it has got a specific morphology. It is concave upward, and it is present globally. That means it is present in almost all precordial and limb leads, but it will of course be better appreciated in precordial leads, and all ECG changes are better appreciated in precordial leads because they see the heart from very close distance. So there will be ST segment elevation with concavity upward in almost all precordial leads. That is the first change. And then it develops into ST segment normalizes, and then there is T wave inversion, again global, because you can't imagine pericarditis affecting one particular part of the pericardium. Once there is any etiology, it could be infection, it could be rheumatic, it could be metabolic, it could be ischemic, post-myocardial infarction, sometime after radiation, or traumatic, or whatever cause of pericarditis may be, it is usually global. So there would be changes present in many leads, not necessarily all, but many leads. And ST segment elevation is followed by T wave inversion. They usually do not overlap. And third stage is normalization over weeks to months. The process evolution in myocardial infarction is in hours to over hours to maybe days, but in pericarditis it is days to weeks. Then ultimately, once patient recovers, ECG is likely to become absolutely normal. So these are the changes. Further comparison, myocardial infarction versus pericarditis. In myocardial infarction, the changes are regional depending upon which artery is affected. It is anterior, posterior, inferior. Whereas in pericarditis, it is generalized because pericarditis always affects the entire pericardium. In myocardial infarction, ST segment elevation overlaps with T wave inversion. ST segment is still elevated, and T waves start inverting. So in many ECGs you would see both. Whereas in pericarditis there is ST segment elevation, but when there is ST segment elevation, T waves are usually upright. Only once ST segment normalizes, only then T wave starts inverting. So in one ECG, you are likely to see either ST segment elevation or T wave inversion depending upon which phase of pericarditis you see the ECG. Then progression over hours to days. These changes, ST segment elevation followed by T wave inversion and followed by Q wave inversion, occurs over hours to maximum days in myocardial infarction, whereas in pericarditis the same changes develop over days, and of course Q wave never develops. And in this patient, ECG becomes normal. Here I think most patients they would continue to have Q waves. The morphology of ST segment elevation in myocardial infarction, you have ST segment elevation with convexity upward. It is convex upward, right? Like this one. And in pericarditis, there is concavity upward. There are conditions other than pericarditis. One of them is early repolarization, where you have this type of morphology. But comparing myocardial infarction with pericarditis, if you have ST segment elevation with the ST segment concave upward, it is more likely to be pericarditis. Another thing is here ST segment is elevated and T wave is inverted. Here ST segment is elevated and T wave is also upright. So ST segment T wave concordance, both are upright. So that is also a feature of pericarditis. Now this is an ECG. If you see this ECG and examine lead 1, 2, 3, and you can of course appreciate ST segment elevation here. Here also some ST segment elevation here also 1, 2, 3, AVR, AVL, AVF. You have significant ST segment elevation in AVF also. Then V1, V2, V3, these are the precordially. I think there is ST segment elevation also. In all of them, you see this, appreciate this concavity. This is concave upward. And T waves are all upright. So this is a case of pericarditis. Of course, you need to know the history. You know, these kind of changes may be normal. Sometimes a perfectly normal person can have some ST segment elevation with concavity upward with upright T waves with normal QRSs. So this may be a normal variant also. I would make a diagnosis of pericarditis in this ECG only if I have the history, and otherwise I would say this ECG is consistent with the diagnosis of pericarditis. These are the criteria. ST segment elevation. I have demonstrated all precordial and limb leads. All limb leads and precordial leads, there is ST segment elevation. And ST and T wave concordance. That means ST segment is above baseline and T wave is also upright. And ST segment elevation and T wave height, the ratio is more than 0.25. This I will explain later when we discuss another differential diagnosis of pericarditis, early repolarization. And then there is PR depression. And it may not be obvious here, but I think I have another ECG where I can show PR interval is also slightly depressed. T wave inversion that follows ST segment normalization. So in this ECG, you see ST segment elevation, but T waves are upright. Only when this ST segment will be normalized, then T waves will start inverting in the same leads, and that will occur maybe after several days. And then there are no Q waves. That is important because this is not infarction. In infarction, you may have Q waves. Here you don't see any Q waves also, any Q waves at all. Of course, you would see the normal physiological Q waves. For example, this is very small, all left-sided precordial leads, and left-sided lead, limb lead also, AVL, they may have small Q wave here also. I think you have normal Q wave that is due to septal depolarization, but no pathological Q wave will be seen in this patient. So this is, I think, very clear pericarditis. The only differential diagnosis would be early repolarization syndrome. If patient has history of pleuritic pain, the pain of the in the chest which increases with breathing and heartbeat, and if you auscultate the patient, you will have very typical biphasic and very classical triphasic murmur. It's so typical, but if you hear once this typical pericarditis murmur, you will never forget. And differential diagnosis of pericarditis would be infective pericarditis, tuberculosis is still common, rheumatic, part of pancreatitis, or viral, Coxsackie B virus, or uremic, metabolic, autoimmune, traumatic, radiation. So all these would come in the differential diagnosis of pericarditis. A tumor in the mediastinum infiltrating into the pericardium may also cause pericarditis. This is another ECG for revision. This is again pericarditis. You can see ST segment elevation in limb lead 1, 2, 3. I think you can, if you compare with BER or TP interval, you can appreciate there is different ST segment elevation. So there is ST segment elevation here, you appreciate here, and you also appreciate concavity upward. You also appreciate the concordance, ST segment elevation, and with upright T wave. So everywhere there is ST segment elevation with concavity upward, and I'm going to show you PR depression. Okay, now I'm going to show you this PR depression. This is PR interval, this one. If you compare it with previous TP, this is truly a reference line. This is TP. Compared to this TP, ST segment is elevated, but PR interval is depressed. This will be seen in precordial lead like in V5. But if you look at AVR, which is a cavity lead, and if you imagine AVR can be considered as reciprocal lead of V5, the changes would be different. This PR depression would be seen as PR elevation in AVR. Let me show you that. See this one. This is AVR. The same pericarditis change is shown in reverse here. ST is depressed, T is inverted, and this, look at this PR interval, it is elevated. Okay, so in pericarditis you can expect, if you examine the ECG very closely, you may see PR depression and PR elevation in AVR. We have covered pericarditis, but this is another condition which can cause changes similar to pericarditis. Let's examine. There is ST segment elevation here. Here there is concavity upward, very noticeable ST segment elevation with concavity upward in limb lead 2. And in precordial leads also you can see ST segment elevation, and you see this J point elevation, and there is a J wave actually. There is a J point elevation. So what is this? Suppose this patient did not have any symptoms at all. Young person just had an ECG just for fun, say, and he was found to have these changes. This is early repolarization syndrome. This is supposedly a fairly common condition with no symptoms, no morbidity attached with it. It is benign condition. That is why we call it benign early repolarization syndrome. But it is often misdiagnosed as pericarditis or ischemic heart disease. So you need to understand this condition and know it, and know the diagnostic point. So what are the criteria? Concave ST segment elevation, usually in V2 to V5. V2 to V5, and there is J point elevation. You see very obvious here and here and here. J point elevation, and no T wave inversion. and these changes are stable. They do not evolve. I think that is very, very important. If you happen to see these changes and if you repeat the changes ECG, the changes would be still there, no change at all. Occasionally these changes may revert, but they do not evolve over time. And then ST segment elevation T wave height ratio is less than 0.25. That means ST segment elevation is minimal. That is what it means. As compared to pericarditis, the ST segment elevation is minimal. Then there will be no reciprocal ST depression. So this is early repolarization syndrome. You need to know it because it can confuse you and patient may be misdiagnosed as a case of pericarditis. Now I'm going to show you the differential diagnosis of three common conditions which are characterized by ST segment elevation: STEMI, pericarditis, and benign early repolarization syndrome. In STEMI, you have a regional convex ST segment elevation overlapping with T wave inversion and finally appearance of Q wave. Okay, we have discussed this in detail. And in pericarditis, global concave ST segment elevation followed by T wave inversion and then finally complete normalization of ECG. And benign early repolarization syndrome, patient is absolutely asymptomatic. There are stable J point elevation and concave ST segment elevation in precordial layers. And these changes, they are usually stable. They do not evolve. So I think this is how to differentiate. Of course, best judgment is the clinical background. If you know the patient, then this differential will become easy. Thank you very much. I hope you like this video. This was a short one, primarily focusing on pericarditis and how to differentiate pericarditis from two other conditions: myocardial infarction, STEMI, and also benign early repolarization syndrome. This has been Professor Azizur Rahman from Medurstand. I really look forward to see you in my next video. Thank you.